So in the phase 2 trial of Ipilimumab, Nivolumab, or Ipilimumab and Nivolumab in relapsed or refractory MDS, we enrolled 55 patients with MDS who progressed on prior hypomethylating agent therapy. Patients received one of 3 treatment regimens: Ipilimumab 3 milligrams per kilogram in 21-day cycles, Nivolumab 3 milligrams per kilogram on days 1 and 15 and 28-day cycles, or Ipilimumab 1 milligram per kilogram on day 1 with Nivolumab 3 milligrams per kilogram on day 1 and 28-day cycles. For patients who progressed on immunotherapy, azacitidine 75 milligrams per meter squared was given on days 1 through 5 and 28-day cycles, while immunotherapy was continued. So in other words, if patients did not respond or they progressed on immunotherapy, then we added on azacitidine while continuing immunotherapy to test the concept of hypomethylating agent resensitization. So the median age of the overall cohort was 70 years. The median IPSS-R score was 4, and the median IPSS-M score was 0.1. Most patients received a median of 3 cycles of therapy in each cohort. Overall, we observed very modest response rates. The overall response rate of the Ipilimumab cohort was 20%. No patient responded to Nivolumab, and the overall response rate of the Ipilimumab-Nivolumab cohort was 16%. There were no differences in the overall response rates between cohorts. GNMT3A mutations and ASXL1 mutations appeared to be associated with response achievement, whereas TET2 mutations appeared to be associated with a lack of response. For patients who progressed on immunotherapy, the addition of azacitidine did not improve the overall response rate compared to immunotherapy alone. The median overall survival between cohorts was not significantly different, at 8.9 months for Ipilimumab, 8 months for Nivolumab, and 8.7 months for Ipilimumab and Nivolumab. In a multivariate model, normal karyotypes, FRONX1 mutations, and surprisingly, complex cytogenetics appeared to be associated with improved overall survival, whereas TP53 mutations, TET2 mutations, monosomy 5, and deletion 7q were associated with worse overall survival. The incidence of immunotherapy-related adverse events across all treatment arms was 44%, which was similar to what we saw in the upfront setting, which occurred more frequently with Ipilimumab and Nivolumab. In this study, skin or endocrine immunotherapy-related adverse events were associated with improved overall survival compared to patients with no immunotherapy-related adverse events. So in summary, PD-1 and CTLA-4 blockade appears to be safe in hypomethylating agent failure MDS, but are associated with only modest clinical activity. Immunotherapy did not resensitize patients to hypomethylating agents, and there appear to be discrete cytogenetic and molecular subsets of MDS which may benefit from immunotherapy-based approaches.